again. I kind of go through marathons of diabetic food files, but welcome back to Diabetic Food Files, the podcast where we don't just treat wounds, we translate them. Maybe be a wound whisperer, I don't know. But I'm your host, Dr. G, and today we're going to be talking about another thing that what the eye cannot see, and what X-ray misses, but what time hasn't revealed as yet. And what we're going to talk about today, again, well, not again, but another topic is bone scans. I don't think people really talk that much about bone scans. I remember when I was studying for boards, bone scans was like one of the difficult things that I just couldn't wrap my head around. I don't know why I couldn't, but I had a really great mentor, and he just pretty much, like, broke it down to me, like, going through the phases with me because I didn't understand it. I was like, "Pooling phase? What is this?" I just kept on thinking about swimming in the pool. I was like, "What is going on?" But, yeah, we're gonna talk about bone scans. So this episode is not about memorizing images. This is about understanding biology in motion because, bone scans don't show bones the way you think they do. They show blood flow. They show cellular activity. They show inflammation, infection, repair, destruction, and healing, often weeks before the anatomy changes, which is fantastic, right? Phenomenal. So, if you treat diabetic feet, if you treat limb threatening infection, if you manage Charcot, osteomyelitis, post op wounds, or unexplained pain, this episode will permanently change how you order imaging. So, take a deep breath in and take a deep breath out, and we're going to go in deep, right? Okay, so what is a bone scan? Okay, what actually is it? A bone scan is not an x ray, it is not a CT, and it is not an MRI. Remember me, I love me an MRI. Okay, remember I said when in doubt, MRI it out, right? But a bone scan is a nuclear medicine study designed to detect bone metabolism. Okay? So let me say it again, bone metabolism. Okay? When you think of metabolism, you think of movement, heat, all that jazz, right? A chemical reaction, right? So this test doesn't ask, what does the bone look like? This test asks, what is the bone doing right now at this moment? Okay? Is the bone repairing? Is the bone inflamed? Is the bone infected? Is the bone dying? Is the bone overworking itself to compensate? Bone scans are functional imaging, not structural imaging, okay? This is why they're so powerful and actually so misunderstood, because you have to think to yourself, like, how often do you get a bone scan, right? So, they're radioactive tracer. So, every bone scan begins with a tracer, okay? Most commonly, the tracer is titanium 99M, which binds to the phosphate compound like MDP or HDP. So the tracer is actually injected intravenously. So it's injected inside of you. Okay. And here's the magic of it, Titanium 99M does not randomly float around your body being like a fairy, like, it selectively binds to the area of bone with high osteoblastic activity. So remember blastic, you think of baby, right? Baby blastic, those are the ones that make the bone, right? And in simple terms, where the bone is being formed, where the bone is being repaired, where the bone is inflamed, where the bone is infected, that is where the tracer goes. Okay. It binds to hydroxyapatite. Forgive me for my pronunciation. Hydroxyapatite type, whatever, crystals. And these are the mineral backbone of bone. Okay. So if the bone turnover rate is high, the uptake rate is high. Like it lights up on the scan, right? Both scans don't show pain; they show effort. Okay. So the physics behind it and how the image is created. So let's talk physics, but don't panic. Because I mean, the only reason I did well in physics is because I studied the book cover to cover, and you know if you read the book, the teacher used very similar questions from the actual textbook. So from my physics class in college. But titanium 99 is radioactive, but in a controlled, safe way. It undergoes something called isomeric transition, okay? Meaning that it releases energy without changing into another element, okay? People who know physics and chemistry know understand that. The energy is released as a gamma radiation. Gamma photons leave the patient's body and are detected by a gamma camera. So inside the gamma camera, photons hit the crystalline crystal, and then the crystal emits a flash of light, and the light is detected by photon multiplier tubes. And the signal is converted into electrical data, and the data is mapped into an image. See, sound as simple as that? So you're not seeing bones, you're seeing energy emission mapped to a location. Okay? And that's why bone scans are not pictures, they're physiological maps. So bone scans, there are three phases of bone scans. This was the area that I had a hard time when it comes to the boards, and thank God for my mentor, whoever you are. I won't say names, but yeah, thank God for you. So if you remember nothing else in this episode, remember this. Bone scans are interpreted by phases, and this is what the boards will do. They will ask you what phase it is in, okay? Phase one is the flow phase. Okay. So this happens immediately after the injection of the tracer. Okay. This phase evaluates the blood perfusion. If blood flow is increased, inflammation or infection is suspected. Okay. So keep that in mind. In the phase one, the flow phase, this happens immediately after injection. This phase evaluates the blood perfusion. Okay. So if the blood flow is increased, that means inflammation or infection is suspected. Okay. Phase two is the blood pool phase. And I think now when you hearing me, you can see why it can be a little confusing. Okay. But they literally test this one. This happens minutes later. So remember, phase one happens immediately. And that's based on blood perfusion. Remember, phase one based on blood perfusion. And if the blood flow increases, that means infection and inflammation is suspected. Phase two is the blood pool phase. This happens minutes afterwards. This evaluates the soft tissue activity. So this is where cellulitis lights up. Okay? Phase three. Phase three is the delayed phase. It happens 2 to 4 hours after, like later. And this is where true bone uptake happens. This is the osteoblastic activity. And listen carefully. In osteomyelitis, okay, osteomyelitis, what is that? Bone infection. Osteomyelitis lights up in all three phases. This is a diagnostic clue. Okay. So if all three phases are lit up, that means it's most likely osteomyelitis. Okie dokie. So, osteomyelitis, why bone scans matter. In diabetic feet, osteomyelitis is rarely obvious in its early phases. I think it takes about 2 weeks for it to show up on x ray. Okay. So, like, if you suspect possible osteomyelitis and you take an X-ray, it doesn't show anything, and like it really does take about 2 weeks for it to show up. So you literally have to let the infection eat the bone, so you can see it, right? But you can get a bone scan to make sure because you want to treat it immediately, right? Correct. So, or you could take a bone biopsy other things. But okay, x-rays can lag for weeks behind an infection, okay? Because you have to see it eat away at the bone. You can't see it like festering and starting to eat in the marrow and things like that. MRI can be limited by hardware, like let's say the patient has a like defibrillator or hardware in them, but there are MRIs for hardware. I believe so. MRIs can be limited with edema or renal disease. Okay, clinical signs can be subtle, but bone metabolism changes early. So that's why scans matter. And when all three phases are hot and heavy and lit up, the flow phase, the pool phase, and the delay phase, bone infection is highly suspected. But here's the danger: bone scans are sensitive, not specific. Okay. And they tell you something is happening, but doesn't really tell you exactly what's happening. That's why you have to understand the whole physiology, physics, and behind all of this. Okay. So, Charcot foot, Charcot versus osteomyelitis. Charcot is a metabolic chaotic like disorder, right? Like Charcot foot is chaotic metabolically, right? The bone is broken down, the joints collapse, there's inflammation everywhere. Remember Charcot, red hot swollen foot, right? So guess what? Charcot also lights up in a bone scan. And these are the things that are going to test you on the boards, okay? And try to trick you. Often diffusely and often in multiple joints. But this is where clinicians get fooled. And like I said, they're going to ask you on this on the board. If they don't correlate, like if it doesn't correlate with the ulcer location, doesn't probe the bone, labs don't correlate, clinical history, they might misdiagnose Charcot as an infection, or even worse, miss an infection and think it's Charcot. Okay. So, how do you interpret the uptake patterns? Okay. Bright areas on the bone scan are what we call hot spots. Okay. Hot spots, bright light, big city, right? Hot spots mean increased blood flow, increased osteoblastic activity. Hot does not mean infection. Okay. Cold spots. Cold spots are areas where there is reduced uptake. Cold spots suggest avascular necrosis, severe ischemia, and bone infarction. And in diabetics with peripheral arterial disease, cold spots matter. So, when we compare bone scans to other imaging, X-rays show late changes. CT shows anatomy, even though I love CT. If you can get it earlier, get it. Okay. MRI shows soft tissue detail. Bone scans show early metabolic changes. And bone scans answer the question: is something biologically active happening here? And other imaging answers: what does it look like? So there are other advanced options when it comes to imaging as well. There's a SPECT CT, which combines a bone scan physiology with a CT anatomy. And this is pretty much a game changer when it comes to foot bones, because like the white blood cells are labels. These are white blood cell label scans that improve specificity for the infection. And PET scans are highly sensitive, but they're quite expensive. So, what are the limitations when it comes to bone scans? Bone scans are not perfect, they're not specific. That's why you need to have the clinical understanding and interpretation of the bone scan. You need to understand what's happening. Like we said, they are non specific, they are influenced by bone healing, they can be falsely negative in severe ischemic areas, and they require interpretation, not just reading. Okay. So, like, literally, I understand why they taught us physics, chemistry, and even calculus. Okay. But in the final moments of this episode on bone scans don't just show you the bone. They don't show you the bone. They show you what the bone is trying to do. Okay? They show you the bone struggling. They show you the bone's response. They show you the bone's life or loss of it. Okay? And it's limb salvage. Knowing that knowledge can change everything, especially when it comes to treatment plan. Okay? So, if you're a diabetic, bone scans are not an optional knowledge. They're a language, and once you learn to read it, this is mostly for clinicians, okay? But sometimes patients could ask, like, "Oh, do you think a bone scan is necessary for me?" You know, but I never tell people what to do. Never try to tell clinicians what to do. I just believe patients should advocate for themselves, because it's not their body parts that are getting missing or getting treated. It's your body part. And like we said, like, it's not reversible. Like, it's not like we can cut a toe now and we can regenerate it as yet. Okay. I'm sure we'll get to that part of our advanced medicine in the future, but not yet. So I don't want anybody to be guessing when it comes to limb salvage. I want everybody to be thorough, knowledgeable, and seeing what they need to see. So, this is the episode on bone scan. This is diabetic foot files. Bones always tell the truth. Toes tell the truth. Wounds tell the truth. And if you know how to listen, you'll see, okay, what it's trying to tell you. And this is Dr. G. Take care of your feet because they take care of you.